meningiomas, or they include malignant meningiomas. And the term meningioma, it was first used by, or first described by Harvey Cushing in 1992 in his publication, where he described those tumors that originate from the meningeal or the dural coverings of the brain and the spinal cord. So talking about epidemiology, meningioma, it comprises around third of the around one third of all the primary CNS tumor, which is nearly equivalent, which is nearly 70% of all primary CNS tumor, as per the data from the United States. According to the report, the incidence is around 5 cases per 1 million persons, and the prevalence is around 97.5%, 5 per 1 million individuals. And the incidence increases with the age, with the incidence sharply increasing beyond the age of 65 years. And talking about the sex-wise incidence, the females are more predisposed for this meningioma, and the female to male ratio is found to be 3:1 in the age group 35 to 54 years. There are different modifiable and non-modifiable risk factors as with many other tumors, and exposure to ionizing radiation is the strongest modifiable risk factors. The literatures have shown that for example, the cranial irradiation in cases of scalp tinea, and those patients who undergo scalp cranial irradiations for other medical causes, and those patients undergoing dental x-rays, especially data from the US, this was that those patients were exposed to ionizing radiations, they have more predisposition for the cranial malignancies. And other modifiable risk factors such as cell phone use, occupational exposures, smoking, cigarette smoking, and head trauma, inconclusive predisposition has been found. And similarly, the non-modifiable risk factors, they include increasing age. I've already said the incidence increases sharply with the age of above 65 years. And other non-modifiable risk factor is the female sex. We have seen that the females, they are more predisposed to this meningioma during their reproductive life. And besides that, there are several hormones which are present in the female. This existence of meningioma has been found to be associated with several hormonal receptors such as progesterones. And besides that, the size of meningioma, they also found to change in size during pregnancy, during menstrual cycle, with menopause. So the female, they are more predisposed to meningioma. And besides that, the established risk factor is the genetic factors. The patients with mutations in neurofibromatosis gene, they are more predisposed to this meningioma. This is the semi-diagrammatic representation of the arachnoid villi, and which shows its relation with the sagittal dural sinus, and the continuity of the layers of this arachnoid villi with the with this arachnoid villi, as well as the arachnoid space with the overlying meninges of the brain. Here I've tried to show that there are the arachnoid villi, they insinuate into the dural venous sinuses, and at some point the venous sinuses endothelium, they are in continuity with the arachnoid cells. So at some special positions, and those cells are known as arachnoid cap cells, and it is from these arachnoid cap cells the meningioma arise. And these arachnoid villi, they are found in many regions of the sinus, such as in the dural sinus, in cavernous sinus, in tuberculum cellae, etc. So as I've already said that the meningioma, they especially arise from arachnoid cap cells, and so the location of meningioma is found especially in those areas where the arachnoid cap cells are present. So since arachnoid cap cells are present throughout the craniospinal axis, so meningioma can be present throughout the craniospinal axis. And anatomical classification, various anatomical classification has been proposed based on the dural attachment, and so according to it, the most common location is the convexity. In the chart, I have tried to show the different locations of the intracranial meningiomas, and from the chart we can see that most of the meningiomas, they are located in, they are found in the supratentorial compartment, and most common site is along the dural venous sinuses in the convexities of the cerebral hemispheres. And next site is the parasagittal area, and next is third most common is the spinal ridge. And they can also be found in intraventricular spaces because few meningioma they also arise from optic nerve sheath as well as from the choroid plexus. So the first picture this shows meningioma arising from the skull base, and the second picture we can see the meningioma arising from the ridge of the sphenoid. In the second picture we can see the base of the sphenoid, above which is we can see the pituitary gland, and on its either side we can see the common carotid artery and optic nerve. So this is the base of the sella turcica. This is the pituitary gland, and this is the carotid artery. This is anterior cerebral artery, and this is the optic nerve. And here we can see the meningioma arising from the ridge of this sella turcica. Now next is the WHO classification. WHO classification has given 3 grades of meningioma, and with the increasing grades, the morbidity as well as mortality of the meningioma is increased. And the first grade is the grade 1. Grade 1 meningioma, they are also known as benign meningioma, and they are defined by the presence of less than 4 mitosis per high power field. And various histological subtypes include meningothelial types, fibrous type, and transitional type, which includes the mixture of both meningothelial and fibrous type, psammomatous, angiomatous, microcytic, secretory, and lymphocyte rich, and next is the metaplastic. These are the histological subtypes of benign or the grade 1 meningioma. And next, the grade 2 meningioma, they are also known as atypical meningioma, and they are characterized by the presence of around 4 to 19 mitosis per 10 high power field, or presence of 3 out of these 5 criteria, and which are diffuse necrosis and high nuclear cytoplasmic ratio, prominent nucleoli, architectural sheathing, hypercellularity, etc. And the whenever only 2 or less than 2 of these 5 criteria are met, they are known as grade 1 tumor with atypical features. And those typical features, they have many obviously higher recurrence rate as compared with just grade 1 meningioma with without atypical features. And the third type is grade 3 meningioma. They are similar to the sarcoma, so they are known as anaplastic or malignant meningioma, and they are defined by the presence of more than 20 mitosis per 10 high power field, and there is loss of cellular differentiation showing frank anaplasia, and the histologic subtypes include papillary or the rhabdoid types. So as we can see from this chart, with the increasing grade, there is increased recurrence rate as well as poor outcomes. And this is in this chart I've tried to show that meningioma, they can also occur because of the somatic mutations, and the most common mutations inculminated for this is the neurofibromatosis 2. The mutation in this gene present under chromosome number 20, which codes for the neurofibromin or Merlin protein. It is responsible for neurofibromatosis, which is associated with multiple meningioma as well as schwannoma, and various other mutations that leads to the development of meningioma include AKT1 mutation, TRAF mutations, etc. And in this chart, I've tried to show the different mutations leading to different meningioma. They are important because the site or the location of the tumors, they are different according to the type of mutation that occurs with the tumors. Now, clinical presentation. And most of the meningiomas, they are asymptomatic or they are diagnosed incidentally during investigation for some other reasons. So, but in case of the symptomatic presence, the clinical presentation depend on the size as well as the location of the tumor. For example, when the tumor is present in the falx and the parasagittal region, the patient generally presents with impaired level of brain functioning. Whenever it is present in the middle section, the patient presents with weakness of the legs or numbness or the seizures. And since the most common site is the convex cities of the cerebral hemispheres, they present with seizures, headache, and the neurological deficits. Sometimes the tumors can present in the posterior fossa, and they give rise to the symptoms such as facial symptoms or loss of hearing due to compression of the oculomotor nerves. And when they present in the inside the ventricles, they present generally presents with obstructive hydrocephalus such as features of raised ICP, headache, vomiting, etc. And when they are present in the intraorbital regions, and they give bulging appearance to the tissue because of the pressure effect, and there's potential loss of vision. And some around 10 to 12% of the meningioma, they have the primary site as the spinal cord. So in such cases, they give rise to back pain or the pain in the limbs. Now talking about the diagnostic modality, in plain X-rays, the typical characteristic features of this meningioma include three features such as hyperostosis, increased vascular marking, and calcification. Plain X-rays are not the modality of investigation for meningioma. In non-contrast CT of the head, we can see the meningioma, they are iso-intense to slightly hyper-intense as compared to the adjacent brain parenchyma, and calcification may be seen in NCCTs. MRI, in MRI we can see uh, the lesion, they enhance intensely, and they intensely and uniformly after the injection of gadolinium with the typical dural tail enhancement. And this is the T1 weighted coronal and axial MRI, in which we can see mass with homogeneous enhancement. uh, and also we can see the enhancement of the adjacent dura, which is known as dural tail. And we can also see the subtle CSF cleft between the tumor as well as the brain parenchyma. So these features are suggestive of meningioma originating from the adjacent dura. And this is tendorial meningioma, in which we can see poor margination of the tumor, likely due to infiltration of the tumor into the midbrain. But also in this picture also we can see the dural tail. And this is another picture where the meningioma has eroded the skull base. In this, there's gross distortion of the anatomy because of the infiltration of the tumor to the bone. Now, next modality of investigation is angiography. This is an adjunct for preoperative assessment of the tumor, and this is basically useful for assessing vascularity of the tumor and vascular supply of the tumor. As we know that these meningioma, they parasitize the surrounding tissue, so they obtain vascular supply from the adjacent meningioma or the parenchyma. So they are generally useful whenever we are approaching the large tumor to control, to gain access to the vascular control. So they are also important in cases to look for feasibility of embolizations, and they are also they can also be helpful in whenever there is presence of tumor encroachment on the vascular structures. And the next modality of investigation is somatostatin receptor scintigraphy using indium octreotide, and this is an extremely sensitive modality of investigation, and it can be used preoperatively whenever there is diagnostic dilemma or whenever the diagnosis is not straightforward. And post-operatively, this modality can be helpful in differentiating the contrast uptake either due to residual tumor volume or due to non-specific hyperperfusion. And next is the immunohistochemistry and the molecular diagnosis. These are basically recent advances in the diagnosis of meningioma. The meningioma, they generally stain positive for vimentin and epithelial membrane antigen and NES100, and they also sometimes show progesterone receptor positive, and they stain negative for GFAP and octreotide. And these are basically important to differentiate from the few differential diagnoses such as solitary meningioma. We have to differentiate them from solitary fibrous tumor of the CNS, and in such cases radiologically they both appear similar, but by immunohistochemistry those solitary fibrous tumor they stain positive for CD34 and vimentin, but they stain negative for EMA and S100. So and under electron microscopy, these meningioma, they typically show tightly interdigitating cellular process held together by desmosomes and molecular and cytogenetics, looking for the underlying genetic mutations, if any. And now next is the next now while going for treatment, as we have already said that most of the meningioma, they are asymptomatic and they are diagnosed during incidental findings. So the question arises that do we need to treat all those meningioma? So the answer is before saying about the treatment, we have to know that uh, most of the recently in this era, since we are getting more advanced investigation modalities, most of the this occult or incidental meningioma, they are diagnosed, and because of the increased lifespan, meningioma incidence has been increasing. So uh, we should know that the tumor growth occurs in uh, 37 to 63% of the in percentage of the patient. Not all the patients with meningioma, they showed tumor growth. So the annual growth rate, it is around 0.54 centimeter in those less than younger than 60 years, whereas it is around 0.83 centimeter cube in those older than 60 years. So we can monitor the patients with asymptomatic meningioma. Those patients, they should not be subjected for surgery. So those patients who are undergoing observation or watchful watching for meningioma, the follow-up strategy for them is we have to do the first imaging with MRI at the 3 months of the initial diagnosis to exclude the rapidly enlarging tumor. And then the next imaging is done at 9 months, and then yearly thereafter. And if the patient is stable for 5 years, then imaging can be tapered to twice, once in a 2 year. And so, and during this follow-up, what we have to see is we have to compare the recent image with the uh, earliest possible image to identify any subtle changes in the tumor pathology. But the exception for this observation in cases of meningioma, there are two exceptions. First is those meningioma which are present in the tuberculum cell meningioma, tuberculum cell, because these tumor, however they are small, they rapidly progress to develop, they rapidly cause visual deterioration. And second exception is meningioma in case of young patients, because they have a very in case they grow more rapidly in case of young patients, because the meningioma diagnosed at a younger age, they generally tend to be malignant or anaplastic type. And next is the surgery. The only definitive curative modality of treatment for meningioma is surgical excision, and surgery should be done for any symptomatic or rapidly enlarging meningiomas. And in 1952, this Simpson has given various grading of this surgical excision of the meningioma. He has given 5 grades of surgical excision. Grade 1 is a macroscopic total removal of the tumor, including dural attachment and the infiltrating bone. And the grade 2 is the macroscopic removal of the tumor, and the dural attachment is only coagulated, not excised. And grade 3 is the macroscopic gross total removal of the tumor, and without resection or coagulation of the dura or the infiltrated tumor. Sorry. And grade 4 is the partial resection of the tumor, and grade 5 is decompression. And when we do Simpson's grade 1 by including 2 centimeter of the dural margin, then that becomes Simpson's grade 0. And this Simpson grading is important because different grades of resection, they are correlated with the different recurrence rate. For example, grade 0 Simpson's grade excision, they have 0 recurrence rate at 5 years. Grade 1 have 9%, and grade 2 have almost double, and so on the recurrence rate. And this Kobayashi, they have given the modification of this Simpson's grading, because in the previous there was macroscopic excision of the tumor, and in this they have modified this grading as per the microscopic extent of the tumor. So basically it is similar in grade 1, 2, and 3, only it has included is the microscopic removal of the tumor. And next is radiation therapy. For any meningioma, the surgical excision is the curative, whereas this radiation therapy, this is generally a temporizing measure. And the four indications for radiation therapy in meningioma includes: first is after the surgery for a malignant meningioma, and second is cases we go for radiation therapy. And different modes of radiation therapy include stereotactic radiosurgery, in which we give different beams of radiations to confront to a tumor, and so that the surrounding normal tissue get less injuries. And conventional modality is a hypofractionated radiation therapy. And chemotherapy, the role of classic chemotherapeutic agent is still disappointing, and there are multiple targets identified for the causation of this meningioma. Therapies has been targeted to such modality, but they are still in the preclinical and clinical trial phase. And the hormonal therapy, they have also been widely investigated, but in conclusion, the role of chemotherapy as well as hormonal therapy, they are not very good. Sir. Thank you. Sir.
Okay, that was a good presentation, Rupesh. Well, I see most of us are there in this meeting. Well, there are a few things which I like to point out. Since you were talking of lot of data, you should always quote the source of your data. So, say for example, when we are talking about the recurrences rate or the improvement rate or chances of growth on observational data, so they should always be backed by which source you are taking. So, and then we also like to know what was the study size. Say for example, if somebody is presenting an observation data, how many cases the patient had been, how many numbers of the patients have been included in that study, and how long was the patient followed. That is important for us. Secondly, there are a few points which I like to make a comment on. One is the history in the presentations. You should always start with the history, or some amount of history about the meningioma. Say for example, who coined the name meningioma, and then who operated the meningioma for the first time. So these types of historical things are also are interesting to note, and sometimes they may appear in some questions also. Regarding the role of embolization is definitely preferred in those cases where we find the meningioma is huge and it is highly vascularized. However, there are certain cases where embolization is not very convenient. Say for example, or it is dangerous. Say for example, the meningioma is in a sphenoid wing and is being supplied by ophthalmic artery. Now, ophthalmic artery supplies the retinal artery also. So henceforth, if in case somebody embolizes the ophthalmic artery, patient can end up becoming blind. So one has to understand that. Other than that, the role of angiography is very important, particularly in those scenarios where we can go for embolization. So in cases where the major arteries of the brain are encased by the tumor, say for example middle cerebral artery or ICA are encased by the tumors, then angiography is an important modality. So that is one test we like to do. Well, I would like you to explain something upon the SRS technique using iridium dye. What was it? Why did you make a comment on that?
So I've read in one article, and they have just mentioned a few lines about it. And they have said that this is the most sensitive investigation modality, and this is basically useful whenever there is diagnostic dilemmas, or whenever the diagnosis is not straightforward by the previous modalities,
No,
and
but then
in a post-operative.
SRS means stereotactic radiosurgery.
No, sir. That is somatostatin receptor scintigraphy, sir. That SRS,
Okay,
that is
talking of
treatment model, that is
scintigraphy.
different.
So in that sense, is always try to write the whole term rather than using short forms. Because whenever you write SRS in neurosurgery, it always means stereotactic radiosurgery. So you should always make a point there. Okay, that's understandable. Scintigraphy is some test which is helpful. Okay, beside this, Dr. Bikram and Dr. Bidur is also on the line. So do you have anything to say?
So, can you hear me? Hello.
Yeah, Bikram, you're audible. Go ahead.
Yeah. Dr. Rupesh, you have chosen
Yes,
a
sir.
very important topic. Meningioma is one of the commonest and gratifying tumor we get in our
Yes,
daily practice. It has been stated by Cushing himself
yes,
during his period that is the one of the most gratifying surgery. That if you remove this meningioma in total, there will be a perfect recovery from the disease. And regarding the sites of this meningioma, it can arise in many sites in the cranium, in the brain. The most common is the convexity meningioma, and which is more easier to remove also.
yes,
And regarding the presentation, as you have said, all the meningiomas doesn't need to be removed. Some of the tumors we can observe, and most of these meningioma, most of the people they die with meningioma rather than due to the meningioma. They most of the time remain clinically silent, and they do not require surgery. Regarding etiology, I think you have not mentioned the etiology part. So though the etiology is not clear, but most of the some of the important things we have to mention in etiology are like trauma, and there has been controversies regarding the etiology being irradiation also, and like with mobile use, maximum use of mobile use also, it has been said that the brain tumor arise, which is meningioma. However, it is still controversial. Mm, and regarding Simpson grading, you should have included this slide, one of the slide, just explaining the Simpson grade, because that will indicate that will give us some idea regarding the prognosis and how the patient life would be following the tumor excision, and how we should follow him up. Uh, and regarding non-surgical treatment, one of the important method we advise the patient is radiation, and the situations where we advise for radiation are after the surgery of the malignant meningioma following incomplete resection of the tumor, and for the patients who need recurrent surgeries. That's the thing.
thank you, sir.
Okay, so Dr. Bikram's comments are well taken, except for the fact that Dr. Rupesh did present a slide on classification of the resection margins, including the microscopic classification too. Well, he did talk about one of the famous comments by Cushing, which he gave in his Cavendish lecture in 1922, that actually suggests how much he had his love for meningiomas. So that statement goes like this: there is today nothing in the whole realm of surgery that the successful removal of a meningioma with subsequent perfect functional recovery, especially should a correct pathological diagnosis has been previously made. So actually this does suggest that they still had during that period a lot of dilemma regarding the diagnosis. And since I was talking about the history part, meningioma was not considered as meningioma when it was first identified by the people. They were calling it with other names. So anybody has an idea as to what was it called before it was called as meningioma?
Meningothelioma.
Meningothelioma or epitheliomas, or even somebody has kept it as hemangioblastoma. So there were a lot of names which was given to it. However, Cushing was the person together with Eisenhardt and Olive Renaud who actually started giving it a name as meningioma. So there's an interesting story about how it was coined and what were the problems in naming it in the first hand. So Bailey and Bossi, in their classification in 1931, Bailey is actually credited with the first classification of cyst. So in that particular classification, he didn't talk it about as meningiomas. Okay, guys, and Dr. Vidur is also online. Vidur, you want to comment something?
Sorry?
के कमेन्ट गर्नुहोस् न
Vidur, you want to comment something?
Hello?
Yeah, we are listening to you.
Vidur sir is here in the classroom itself.
So Vidur is already there in the classroom.
I was just trying from mobile.
Okay, so any comment?
No comment.
No comment. Okay, that was a good presentation, Rupesh, and I think the next presentation can be taken up by Dr. Bibesh. So Bibesh, are you ready with the topic for tomorrow?
Yes, sir.
So tomorrow is what? Tomorrow is the holiday.
Yes, sir. Tomorrow is
Yes, sir.
Okay, guys. So that's okay then, and the nice presentation. So we can continue like this.
Thank you, sir, and happy New Year to everyone.
So tomorrow also we'll start at 1, sir.